Thank you. Again, I'm really pleased to be here and to have this launch happening. I'm going to kind of be bringing some things together here. I will be presenting some data that Larry and I were looking in some of the same places for some of the international information and bringing that into what it means for health through some of the research that we've done and research that's been done in the United States with other populations. And I'll be talking a little bit about the policy arm of the program that we're launching, that we got a pilot grant from public policy, Stanford School of Public Policy, to start. So I'll talk a little bit about that and how we hope to move forward and be useful to everyone in the room, I hope. First, let me say one of the things that I was talking to my students about in public policy is what is a policymaker? And we think about policymakers in terms of people who are political leaders and elected officials and people at the UN and the state, North Carolina. Anyone who's making decisions for a group of people is a policymaker. So right now, Ashley is our policymaker in the room. And there is a trickle down in what policymakers can do. And so when we look internationally, we look first at, let's see if there's a pointer on here also. Looking here, this is criminalization of consensual same-sex acts between adults. Here is death penalty. So if you come out, if you are found, if someone wants to act as if they've found you, like some of the police in Kenya and places I've been, it is legislation that you will be killed. I had a conversation with a woman from Ethiopia we were hosting. We had people from Kenya and Cambodia in the room, in my living room, and got late in the evening, and all of a sudden she looked at me and said, "In my country, you would be stoned to death." And there was silence, and then we all started laughing. Then, yeah. Pretty horrible to live under that. Again, in Kenya, met many people running from Uganda. You've got refugees who are not recognized as refugees migrating around and trying to deal with these things. 30 years life in prison. Surviving that, many places, including the US, is difficult, up to 8 years in prison, de facto criminalization, and then we've got uneven protections, and that's where the US is. Then you've got employment protections, broad protection, and full protections. So great diversity around the world. What these allow us to do is when you've got national policies or international policies, they can start trickling down and can allow people like providers at Duke and the Duke healthcare system, depending on what's happening in our nation and in our state, to then try and enforce change. Without these, it becomes, without positive policies, it becomes very, very difficult. This is a map they're starting. This is kind of interesting. I liked it because it shows how we're beginning to do research that has never been done before. So on this side, we've got condemnation of sexual orientation. And on here, you've got country-level structural stigma. And the proportion, the size of the bubble is how many people are hidden. So this is the hiddenness of sexual and gender minorities around the world based on the policies that are in those countries and the number of people living in those countries. So to bring that down to some work that we've done, as Sarah LeGrand, Dr. LeGrand said earlier, you can look at some of the posters in the back room later. We did a study with sexual and gender minorities in Cambodia, Vietnam, Kenya, El Salvador, Brazil, and India. For reasons I won't explain, we don't have India data up here. We charge the people, the organizations that we've been working with. We work with grassroots organizations that are of that place. people, leaders, decisions are all made by people from that place. And we said, and these are people who have been committed to children who've been abandoned or orphaned, vulnerable, some to HIV, say, can you find transgender women, transgender men, women attracted to women, men attracted to men, regardless of behavior? And will they engage with you? Can we ask questions about mental health, well-being, all of that? One of the things we intentionally said we would not do is ask about sexual behavior, because so much of the work has been done around HIV. That's where a lot of the funding has happened, has been, which is great and has been able to really help people and open up different areas of research. And we had people who said in each of the countries in one way or another, thank you so much for not treating us like HIV vectors. One of the things that we've talked about is that there's nothing biologically inherent in being on the gender spectrum, in being transgender, that makes one susceptible to HIV. What makes one susceptible to HIV is behaviors, and oftentimes those behaviors are there because of those policies that are in place. Because if you're in Kenya and you're in middle school and you start to look different, act differently, the sexual violence that occurs and the inability to continue in school, this was told to me repeatedly in Kenya and other areas. I'm just using, this is a real life situation, right? You're not gonna make it through school. Then you don't make it through school and you have a difficult time getting a job. You can't get a job. Employers won't hire you. What are you going to do? The opportunity I have is in sex work. None of the people grew up thinking that's what I want to be, and gosh, I'd love to be transgender so I can be a sex worker, which seems to be what many people think. And because so much funding has come from HIV, we think of people on the gender spectrum as all being highly susceptible to HIV. But that's because of what we've created in society. Right? And I really want to bring that home because it's hard, particularly for those of us, including myself, who've been enmeshed in the HIV world, to recognize that this is really about, what we're talking about is well-being and people. Okay, so let me just explain this quickly. We've got colors here. This is very confusing. You can look at it back. Cambodia, Vietnam, El Salvador, Brazil, Kenya. We did not include all minority statuses: transgender women, women attracted to women, transgender men, men attracted to men, bi-attracted. We have suicidal ideation here, and PTSD. And what we find is that there are differences by country, there are differences by orientation, and by identity. So as we talked about earlier, it's really important that we not lump everyone into the same group as we move forward. And if you go back and forth between the previous slide, there are differences by the country level policies. I'm going to move forward and then I'll come back for a second. This is, I wanted to bring up the slide. We have lots of data, but one was around healthcare, discrimination in the healthcare system. And again, transgender women, men, women attracted to women, bi-attracted, and by country. Again, there are differences, and those differences match up with cultural characteristics, with religious orientation, evangelical presence and uptake, more Buddhist kind of philosophies, and things. So all of this, again, really important, related to policies. Given a chance not to be a sexual gender minority, given a chance not to be yourself, would you take that? Again, looking at differences by country. In Brazil, where we have the highest reported rate of murders of transgender women, only 2% said I would want to change. Also lower rates, the earlier slide, of suicidality. High rates of depression. What do we think might be happening here is that in Brazil, because there are policies that are more affirming, while it's terrible and there's personal violence, I shouldn't say while, it's terrible and there's personal violence, it's scary, people are also joining together and we're able to gather data. In Kenya, you can't gather data. In Uganda, you can't gather data. It's illegal to exist. You can be killed. So seeing the differences, being able to explore that is really important, and important for our states in the United States. So here I just want to say there are over 40 policies moving forward in the United States, positive, negative, kind of inflicting back and forth. If we look at another, I'm just going to say, because we're going to look at another map, negative laws are things like religious exemptions, as was talked about, for being able to provide care, the HIV criminalization, as we talked about. And so when we look at the United States also, as was pointed out, the dark red is where you have negative gender identity policies. In this next map, it's by sexual orientation. As we look at the policies, they're going to be important for what we're able to do. So I encourage all of you to, in research that you're planning, think about thinking about policy ahead of time. Who are the funders? How do we work with Medicaid? How do we engage with different policymakers? Who is it who's talking to the president in Uganda? Who is it who is evangelical, who can talk with some of our church members and pastors and things? Really important to do all of that. So I'm going to close. This is saying in rural areas it's really bad also. Got low. Anyway, won't go into. I'll stop. What I do want to say is that the program that we're launching, what we're starting now is to try and warehouse the databases from around the country and the world that include SGM questions, relate it to health, be able to link it to the different national longitudinal health databases, international also. We want to be the ones and be actively engaged in looking at the quality of those questions. So are we asking gender completely separately from attraction and sexual orientation? And be able to have that so someone can say, okay, I've got this database, let me go and look at this site and see how good that data is and what are the problems going to be and what can I do with it? So we're excited about moving that piece forward. All right, thank you.